So we've been talking about fetal monitoring in special circumstances. We've had a session on pyrexia, chorioamnitis, clinical and subclinical. Had a session on medications. We're going to be talking about meconium today. Yeah? And we're going to end up with a very sad slide on the discussion, or a very scary slide, not sad, scary. Okay. Let's start with meconium. So, what's meconium? Yeah. Okay. What's it made of? Okay, and likewise, yeah, because it does filter through as well. Okay, so why do we care about meconium? Why do we care when we see meconium in likewise? Okay, are most of the babies that you see with meconium distressed?
No, if it's a late gestation, then it's almost physiological, so you don't worry about that. If it's an earlier, it's possibly.
But the reality is that most babies pass meconium because they can, okay? Because it's physiological, because their bowels are mature and that they can pass meconium, okay? And so we talk about first stage babies, yeah. And in second stage, you do head compression. So when you've not seen anything at all, you actually seen clear liquor passing through, and as the baby's head's coming out, then you start seeing meconium coming out. Okay, I mean, if the rest of liquor is completely meconium, yes, then you know that there's meconium behind. But if it just passes that towards the end because of the intense head compression, the prolonged vagal stimulation from that compression causes fresh meconium. Yeah. But as you correctly said, babies can be hypoxic, which is why they're passing meconium. Okay. Now, and in preterm, it usually occurs with either intraventricular hemorrhage, so baby has a hemorrhage, something that's increasing its intracranial pressure, okay, or it actually has diarrhea, so it has an infection causing diarrhea. In a similar way, IUGR babies and PCOM, yeah, they can have meconium. Okay, so what? Meconium is passed. We know that meconium is passed. What risk can meconium in itself bring upon baby? That's the first thing that we always think about, yeah? Meconium aspiration syndrome. Anything else? Chorioamnitis and the hypoxia that already started. Okay, so always keep that in mind because it's not just about the meconium, it's also the hypoxia in labor. So, meconium aspiration syndrome, shall we start with that? What's meconium aspiration syndrome?
So when the baby aspirates,
so you mean the meconium going into baby's lungs?
Yeah.
Okay. The fact is, if you can see meconium in the light port, it's already in baby's lungs. Too late. So meconium aspiration syndrome is all of it together. Now, small amounts of meconium, unless it's breach, you see meconium that's just passing straight out. But small amounts of meconium the baby can figure out. It can break it down and it can absorb it as chemicals rather than anything else. Small amounts of meconium also get, so the surfactant and the protective mechanisms within the lungs actually keep it away from the lungs. But we'll talk about small amounts. Okay. But large amounts, obviously they're particulate, so they can cause airway obstruction. Mm-hmm. Airway obstruction can be complete, which means that you either fail to inflate, so if there's a block, the rest of the lung is inflating, but that tiny bit there, it's not. Okay? Or you can have atelectasis, so you start filling up, it fills up, it inflates initially, but then blocks. And with time, this is ongoing, but the air starts getting absorbed and ends up again collapsed. Okay. If it is partial obstruction, though, the meconium can start acting like a ball valve effect. So air goes in, can't come out, more air goes in, can't come out. And you end up with emphysema. Okay? So yes, you can have a baby then with a collapsed lung or a hyperinflated lung. both of which are actually because of obstruction. Okay. Meconium is not inert. Meconium contains lots of digestive enzymes. It can break down the lungs. It can break down the surfactant. Okay. It contains bile. Surfactant is supposed to be a water, fat. Well, what's it called? A bilipid thing. So it actually makes breaks down the lipids, makes it actually soluble in the water of the liquor. Okay. So it can cause surfactant dysfunction as well. So that's meconium aspiration syndrome. What about chorioamnitis? Meconium in itself is actually aseptic. So why would it cause chorioamnitis? It's a good culture medium for bacteria, and also it inhibits the leakage of phagocytosis. Yeah. So, and don't forget the initial hypoxia, being chronic hypoxia, like the babies that of IUGR babies or babies of smoking mothers. Okay, or obviously the gradually evolving hypoxia. Okay, so now we know how to diagnose meconium. You see green in the waters. The lady actually comes and tells us about that. Yes, but what's the problem? How can we figure out meconium aspiration syndrome? Can we figure out chorioamnitis? Can we figure out hypoxia? So, what do we need to look out for? One, why is this baby passing meconium? Is it passing meconium because it can, or is it passing meconium because it's hypoxic? Okay, and if it's hypoxia, which type of hypoxia, obviously? Now, we can potentially predict the meconium aspiration syndrome. We said it's already present in the baby's lungs. Okay? We don't want a lot of it to be there, though. So what we can predict is the things that can make the baby gasp, to take more and more meconium inside. What makes the baby breathe at birth? Hypoxia. So the cord getting compressed, or the cord stopping its flow through it. Yeah, vasoconstriction through the cord. So if you actually have recurrent deep, wide decelerations, so cord gets compressed, the baby is becoming hypoxic, respiratory center gets stimulated. Maybe I've been born. Let's take a deep breath in. Oh, actually, I haven't. Now it's trying to let all that meconium out, but the reality is, with it trying to breathe out, the thick meconium is going to stay inside. It's only the light meconium with the light liquor that's going to leave, just because that's how the fluids happen. Remember, when you're taking a deep breath in, you have a wider airway than when you're trying to breathe out, which is the whole idea about asthma. Yeah. Okay. What about chorioamnitis? Can you detect that?
What, with the CTG?
Yeah.
Yeah, so it takes like.
Okay. So, what we used to describe in the past as the uncomplicated tachycardia. Yeah. There's nothing uncomplicated about tachycardia. So always remember that. Okay. How do you manage meconium stain battery? So, making the diagnosis start with, we see the green. Okay. What about thin and thick? What difference does it make?
Still, something saying meconium is really.
Yeah. Okay.
But I guess if it's thick, then you've got to make this aspiration.
Okay. So the problem with thin and thick is it's much more complicated than that. So it's not just about babies pass thin meconium, so this is fine. What does thin meconium tell you, and what does thick meconium tell you?
In meconium, I guess you'd say that there's more amniotic fluid in there.
That's one. Okay. But also, yeah.
That's likely that aspiration is a problem.
Okay, let's leave that to the end. I'll explain why. So thin meconium tells you there's more liquor inside, but it also tells you that it's been there for a while. This is not something new. This is probably they've been doing that for the last few days, weeks, etc. Yeah, okay. And it can still be So it has good kidney functions, and it's also opening its bowel. But it also tells you that this baby's bowel is working. So it's not going to take a lot of stimulation to make this baby pass meconium again. So you can end up with fresh meconium. Very easy, yeah? You can easily end up with fresh meconium. Okay. Now, when we look at thin meconium, where did this liquor / meconium come from? It's usually from the forewaters. What's in front of the baby's head. What about what's behind the baby? Can we see that? We can't. So if there's fresh meconium right now, where is that coming from? Behind the baby. Yeah, it's coming from the baby's bottom. And where is baby's mouth? Is it in the forewaters or is it in the hindwaters? Baby's mouth. It's in the hindwaters. The forewaters are gone. Okay, baby's mouth is behind that seal with its head. So whatever's going to be breathing or aspirating is actually behind.
Do you know what it's breathing?
So I really have no idea what it's breathing. And I know that this baby can easily pass meconium if it wants to. Okay? So that's why thin versus thick, I really don't believe that there's a difference. Either or, keep them on continuous monitoring. Why continuous monitoring? Why continuous monitoring? Can you not detect hypoxia with intermittent auscultation? And likewise, can you not detect chorea with intermittent auscultation? You'll see the rise in baseline with choreamnitis, and similarly, if you have hypoxia or graduate hypoxia and rise in baseline, you'll see that with intermittent auscultation. So why continuous monitoring? Okay, let's suppose that you're doing the perfect standard textbook intermittent auscultation. Which goes first? Does the baseline rise first, or does the gradient go first? Baseline always comes up first. So you can still detect it. But why am I making a fuss about continuous monitoring if I can detect it with intermittent auscultation? Why don't I just let the low-risk thin meconium ladies have the intermittent auscultation that our guidelines say they should? And you said complications about meconium stained liquor. The first thing you said was meconium aspiration. If you're doing, yes. When are those widened DA cells happening? They can happen at any stage, but the timing in regarding to the contraction, when are they happening? During the contraction. Okay? But when you do auscultation, you're listening after the contraction. So you are deliberately missing the deep wide deceleration, because if there is no other reason, okay, we're trying to get these, yeah? So we are trying to actually, if the baby is here liquor, we're trying to miss these. We're not trying to find them. Yes, you can pick up the rise in baseline, but that would be too late. And remember, yes, we're looking for hypoxia as a cause, and potentially if it's getting worse, but also I want to make sure that this baby is not getting meconium aspiration as much as I can. Yeah? Does that make sense? That's why intermittent auscultation wouldn't work. Okay. Uncomplicated tachycardia, you can definitely look out for. Yeah, it's easy. Okay. We're aiming for a vaginal delivery. Why? Because that's what we're aiming for everyone. That's you. But in a baby with meconium, I actually would love more than anyone else for her to have a vaginal delivery. Because the compression through the birth canal or through the vaginal area empties about a third of whatever is inside the lungs. So even if the baby's lungs are completely full with meconium, at least you now have a third of the space. Okay?
Is that like a documented thing, that cesarean section as well as vaginal?
So how can you run that trial? So theoretically, that's what you want. But the reality is, you need to make sure that this baby is born in a good condition to figure itself out. Right? There's no use having the baby that's lungs are full of meconium, can't breathe, and also hypoxic, and now you're supposed to be supporting it. Yeah? Okay. So at delivery, one of the things that has come up from other hospitals that I've actually so I teach at, was that, okay, they've seen meconium, the baby was showing this recurrent trace, okay, we think it's meconium aspiration, and baby gets born and it's actually in good condition. Okay? It starts off trying to cry, its heart rate is fine, it's pink, but once you clamp the cord, this baby is suddenly crashing. Because remember, the baby is supposed to be switching from cord placenta oxygen to lung oxygen, but his lungs are not functioning yet. So the baby gets born in a really good condition and then suddenly drops. So just take a moment. Once the baby is born, we're going to treat the baby similar to anyone else. Okay? So baby gets born and we are going to see whether what's the heart rate, whether baby is pinking up or not. All good. Make sure that don't cut the cord when the baby's already hypoxic, if you can. Okay? Remember that the whole point, you're trying to get a balance of, okay, I'm not hypoxic and trying to figure out a lung, but at the same time, I don't really I'm not going to wait till the baby, okay, baby's continuously bradycardic. Am I just going to wait? Okay, how long can I wait for? It's the balance between, okay, I need to get this baby to the neonates to sort it out, but also I don't want to be rushing too much because I don't want baby to be under too much stress. Remember, if the baby starts off from an oxygenated point, that's a very good point. Because the moment you clamp the cord, this baby is going to have to figure itself out. Does that make sense? Okay. Okay, so there was a debate in the very, very old days when dinosaurs still used to roam the earth. We used to suction. Yeah. Okay. I never thought that we were getting anything important. Most of these tubes that we were pushing down were actually going to the back of the mouth and the esophagus rather than anything else. Okay. Even if you're getting down to the larynx, remember if you see the anesthetist, they would tell you the moment you touch the cords, they spasm and you can't get the tube down anymore. So if you're trying to intubate once and you hit the cords along the way, they can't intubate. That's it. It's blocked because it's gone into spasm. That's what the cords are physiologically designed to do, so that you don't aspirate. If you start shoving things down the baby's throat or actually trachea, then this baby is not going to start breathing. It's actually going to become more and more hypoxic.
So when you said the baby's out, if the baby's not hypoxic.
So the baby comes out. The first thing I always do is I feel the baby's pulsation, the cord. Okay, if the pulsations are fine, or if they're picking up, because sometimes with that bit of compression, there's always a bit of a slowing down. Okay? But once the compression is gone and the baby's out, you can literally feel the baby's pulsations.
Yeah.
If they are picking up quickly, that's great. Okay, you can leave the baby for a bit, let it oxygenate. If it's starting to cry, even better. Okay. If the baby is not picking up, it is bradycardia. Obviously, clamp and send it to the
So
neonates.
basically saying those that are compromised with oxygen at birth are less likely to be able to sort out.
Yes. Yes. Okay. But unfortunately, you still need to support them. So we can either let them help themselves or we can help them. Okay. You're trying to get the balance. So what I'm trying to say is there is no hard and fast rule for meconium. It's not about, yes, we have to have the minute. No, it depends upon what the baby is doing. Ideally, I would like this baby to have a better oxygen status before I divide the cord. But that doesn't mean under any circumstance. I'm not just going to wait until this baby gets damaged. Because remember, this baby might have been hypoxic from the beginning. Okay? Does that make sense? Okay. So, as I said, focus on the neonatal heart rate at and after delivery and assess. So that's meconium in a nutshell. Okay. Any questions about meconium? Do we have anyone else who's here? Hang on. Oh,
if you were anticipating that the baby is a higher risk of aspiration the lungs themselves, should be enough to expedite the
Not necessarily. So try and improve the fetal condition. Make sure that we're not in a position that's causing the baby to have prolonged white decelerations. So try changing the mom's position.
Yeah.
Try making sure that the contractions are not too frequent.
Yeah.
Okay.
So change the position and consider traditional.
Yes. It doesn't mean you have to do a cesarean section.
Not a cesarean section, but I mean, if someone was fully and you were seeing those kind of T cells, would that make you think, oh, maybe I should not give her an hour to push? And
Okay. So that's an interesting question. So, okay, I have a lady that is now fully, she's just about to start pushing, and I know that there's meconium and there's recurring foot compression. Do I expedite delivery? Okay. So what would expediting delivery do? So how are you going to expedite delivery? You're going to do a forceps, for instance? You're probably going to do more of a forceps than a kiwi. Forceps causes a bit more vagal stimulation, so that can actually increase meconium. However, well, we're only doing it for 5 to 10 minutes. Can it make the baby aspirate more? Right? Remember that with the baby's head being squashed, baby's brain thinks that there is more hypoxia happening. Okay? So that's, and we don't necessarily need to. The problem is not even instrumental. The problem is many people, okay, let's start her pushing now. With a higher head, higher chance of becoming hypoxic. Potentially even pushing up the symptom because now we want the contractions to get even stronger. Okay?
So actually, you're better off giving her a longer time with
Yes. As long as she's not getting, because the meconium is already inside, we don't want more and more. We want to avoid the pattern that triggers the gasping, okay? Which we know is the YD decelerations. The more we push, the more likely we're going to end up with that pattern. Okay? If you wait, give it the time, most of the babies are much lower. Then if you're going to do an instrumental, it's an easier delivery. Then if she's going to push, it's a shorter time for pushing. Does that make sense?
Yeah.
For what? So that's there's very old papers talking about these patterns, okay, or those triggers, and there's not been any papers from this proven. But as I said, it's tricky to figure out how can you randomize that. Keep on going with those decelerations and see what's going to happen. In retrospect, it's always much more difficult. Okay? It's not as accurate, and the old papers they're quite old. So that's meconium. Now this is a really important one, especially where now that you guys are moving away. Pre-existing brain injury. So unfortunately, many babies that we see, one of the things that has made the biggest improvements, I think, when we started physiology was the babies that are not fit for labor. Or the babies that start off labor injured. Those are the babies that you wait a little bit longer, so you wait an hour, and by the end of your hour, this is your baby now. Okay, you missed the diagnosis, you're potentially you're potentially giving the chance for somebody to actually look, okay, well, there was negligence there. You did not diagnose, or you've harmed this baby in a way. Because you didn't do much, but you may have actually, it's your baby, it's your responsibility. Does that make sense? It's very important to figure out the baby that already comes with pre-existing brain injury. What do you think is, what do you think it would look like on a CTG? My baseline? Why? Okay. Okay. But you're describing a baby that's decompensating after gradually evolving hypoxia. Now, what we forget is, where does the catecholamine come from? The adrenal gland. The adrenal gland is part of the sympathetic nervous system. If you have no sympathetic nervous system, you have no adrenal gland. So, if you remember when we talk about fetal heart rate control, the heart can beat on its own at a rate between 120 to 140. If you take the brain away, take it out of the heart, out of the body, it will pump on its own 120 to 140. That's basic heart rate. It's the brain that modifies this rate. Makes it higher if sympathetic, lower if parasympathetic. And the interaction causes the variability. So the baseline actually will most likely be normal. Scary. It's going to probably be normal. Variability?
It won't really have anything.
It will be either completely flat
Mm-hmm.
or reduced. Okay?
It won't have acceleration.
And more importantly, it won't have cycling. Okay? There will be no cycling. Okay? You're saying it won't have accelerations. We don't care about accelerations in labor. She's coming in and she's contracting. It won't have accelerations, but that's not an abnormal thing. So what? That it doesn't have accelerations.
It wouldn't have decelerations either.
It wouldn't have decelerations. It wouldn't have responses.
Yeah.
Okay. So accelerations is a response.
Mm-hmm.
Okay. It might not have need to accelerate at the moment because it's in a conserving energy mode because she's in labor. But if you poke it, it's not going to accelerate.
Mm-hmm.
Okay. If you try and stimulate this baby, it's not going to accelerate. If you get a cord compression, it's not going to decelerate. But is that a good sign or a bad sign? You don't know when the baby is getting cord compressions. Unless you can go inside and actually squeeze the cord and see whether it's going to decelerate or not, you can't know whether there are cord compressions that can go in. So what the most common picture that you see with brain injury is a persistent non-reactive heart rate.
Mm-hmm.
Okay? And it's usually fixed with minimal or absent variability. That is the most classical picture of a brain injury. However, it's not a uniform thing. And unfortunately, so a study, 300 neurologically impaired term singletons, 54% had from injury before, and the one half had normal fetal heart rate pattern. That's scary. If you can't diagnose, if the pattern is normal, it's not on you, because we can only do what we can see. We can't diagnose what we don't know. Okay. Now, why am I talking about pre-existing brain injury, especially before you guys leave? Why is it important? So, pre-existing brain injury is one of the things that frequently puts you into trouble. Okay. You've seen that there's a problem. How do you respond to that now? I've seen that this baby has a brain injury, or most likely has a brain injury. What do I do? Do I do a category 1 section? Do I do a category 2 section? How do I manage this? Do I do a section at all? I mean, am I going to save this baby in any way? Baby already has a brain injury. Do I also damage mom? How do you make?
If it has a brain injury, labor will make it worse. Well,
potentially.
Well, who knows?
That's the whole point. I don't know. One of the other problems is that if baby has a brain injury, I have no idea of knowing that this baby is hypoxic, because all the signs that we're looking for on the trace are gone.
Then you've got no choice.
Is it fair? Okay. So, and what if a complication happens? So you get a bladder injury or a bowel injury doing that, and you're doing a section for a already damaged baby. How do you stand with that? Okay. So, number one, call a friend. Do not make a decision. Do not manage this baby on your own. Okay? And that's a very, very serious point. Do not manage this baby on your own. Personal story. So, one of the ladies I diagnosed with, unfortunately, damage has already happened, was a 36-weeker that was being induced for PET. I saw her at the beginning of my shift. She had a propus, and she was absolutely fine. Okay? Saw the trace, completely normal. Okay? And wasn't really contracting, or was not actually reporting any contractions. She had the last CTG at 12 at midnight, and was woken up at 6 in the morning, so she was woken up to have the repeat CTG. Okay. Midwife puts her on the CTG. The lady is contracting 10 in 10 with a completely flat trace, baseline of 130, completely flat, with just a wavy pattern, absolutely nothing else. Okay. Are you contracting? Not at all. Are you in pain? No. You're contracting 10 in 10. Are you in pain? No. Okay, so I have no idea what's going on there. Okay, let's just get through everything. Let's see what this baby is doing. Try to stimulate the baby. There was no responses there. This is now happening. So 6 o'clock, she's trying to get her on the monitor. She goes to the toilet first. So knock off the contraction and try and do a VE and see how far she's dilated and stimulate the baby's head. But by this now, it's coming to about 7:15. So she had about half an hour. She wants to go to the toilet first, into her bladder, blah, blah, blah. So it took it from 6 to about 7:15. She had 20 minutes of trace before I got called, and it's now by now 7:15. And I've seen this trace. Oh my God, what are we going to do? So the next team is supposed to be starting at 8. Okay, but we have give it to the team 5 to 10 minutes. There's no improvement at all, and we're talking about okay. I think this is the situation. I explained it very clearly to the parents. I said that I think that the baby has already suffered this, and once you give it to gluten, oh my God, this feels so much better. I thought you were not in pain. What was your problem? What's better? Oh yeah, but it was really, really tight. Now it's much, much nicer. And now she's contracting 4 and 10 with absolutely no responses. My colleague walks onto the ward at 7:45 and looks at the trace. We're now moving to an urgent category 2 cesarean section. Oh my God, category 1 cesarean section now! And she gets yanked out of bed. She gets taken to theater, gets given a GA. Okay, and the baby is delivered obviously with an HIE 3. No surprise. But she's waking up now to find, when they've had a GA, by the way, everything that has happened before that GA has literally just been erased. That's something that's very important because the GA makes a little bit of an amnesia for about half an hour to an hour before. And that's something that needs to know. Okay? Which is great because when they go to bed screaming or go to sleep screaming, they're usually not screaming when they wake up. Yeah. Sorry? A bit of memory loss, that's fine. But the reality is, so obviously this is now being investigated. Why did you not act sooner? Why did you not do a category 1 at 7? Because this baby's already stuck. Right? It wouldn't change the outcome for the baby. I may have potentially damaged mum. If I'm rushing now to do a cesarean section, a category 1 cesarean section at handover time, 7:30 in the morning is always the problem. Yeah? 7:30 to 8 is always a problem. So handover time, I'm now trying to people are trying to push it a little bit further, push it a little bit back. I'm going to upset everyone. We're all going to be rushing. And if I damage her in the process, there's nothing to gain. Okay? The thing that stopped the lady from actually, okay, so the result of the investigation, we feel that we don't know what the outcome was if it had been a category 1. That was the person investigating. Okay? This was escalated even further, and it was when it actually went out to actually say, damage is already done. Baby's showing signs of brain injury already. Okay? And the lady didn't go any further medically because he told me that. He said to me that there is actually a brain injury, most likely a brain injury already. So I knew about it. Oh, we're sorry that this has happened. We might have been delayed. No, I was told that this probably happened before I was monitored. Okay. She had a complete normal trace before she went to bed. And I said she woke up with a contracting 10 and 10 when we woke her up. She could not feel the contractions. And within those 6 hours, this damage happened. Okay? Sorry? No, not at all. You mean before? I don't think it was on IGR. She was being used just because of high blood pressure, persistently high blood pressure, but it wasn't on IGR. At section there was oliguria, but it wasn't nothing much. Okay, so keep that in mind. That is a very, very important thing. Remember, we work with physiology here. Okay, not all the units that you're going to be going to work with physiology, so it's important to make sure that something like that is addressed and you have the chat before anything happens. Okay, because in reality, did I need to do a cesarean section for that lady? Okay. Most women, in reality, they will ask for a cesarean section. Okay. Let me show you this. Oh, sorry. This one, yeah. So, gravid 4, paranoid plus 3. She is known to have a history of endometriosis. This is a third attempt at IVF pregnancy. She's pregnant for 30 weeks. Okay. She called in the evening saying, okay, I have reducible movements, and was told, okay, come in, we can check you out. And then she called a little bit later, she felt the movements are now okay. She's not worried anymore. She calls the next day with no fetal movements at all. We've just talked about that's the specific thing. So this is another case that, can you see the trace? Okay. You see, so baseline of 140 with 0 variability. Okay, well, what's that? I thought that looks like variability. So that's very likely mum. Okay. One of the other important things about brain damage, remember, the two things that can slow down the heart. Hypoxia or ischemia can directly slow down the heart. The heart will stop beating until it gets the oxygen that it requires to beat. So the reality is that when you get a contraction, you may get what looks like a deceleration or a squiggly. Okay, and then it returns for it. Okay, so the good thing here was that, okay, we've recognized this. Let's discontinue the trace and she's being moved to labor ward. Within the hour, there's 2 consultants that are now seeing her. Okay, this is now the discussion. You can see mom is actually becoming significantly tachycardic there with the discussion, and they decide to go with a category 1. But the reality it was an urgent category 2, and that's the trace there. The baby came out, so we could see brain damage from the beginning. The whole point is the first hour is the golden hour, as always. Okay? If you make the diagnosis, if you see that and you make the diagnosis in the beginning, you have made the diagnosis. If you miss that diagnosis at the beginning, problems are going to start. Because then all your management is going to get questioned. But the reality is, if I see this, what am I supposed to do about it? There's nothing I could have done to damage this further. But that's only going to happen when somebody understands what they're looking at. And remember, when we're reviewing, when cases get reviewed, we've all been there, we've all seen how it happens. Retrospect is an easy, very easy place to be. Yeah, I've seen this, so I can see that from the beginning, just being here for an hour, and I've counted the hour. Yes, but when I saw her at the beginning of the hour, I did not see what's going to come for the next hour. And it's very, very difficult then. So the ones that have high baseline are the ones that are being damaged or are getting damaged now. So if there is the chronic hypoxia ones, most of them, they have the redistribution that happens antenatal is based on an adrenal that has a slightly higher base rate. Okay, so they run at a slightly higher baseline, or they have grown, they're okay, but they have very little reserve. So the moment they start becoming hypoxic, they jump straight to the compensation phase. So they have more adrenaline, and then they start decompensating, so you have a higher baseline. Okay, while if the brain is gone and it's completely gone, you can't work the adrenaline. The adrenal gland is not going to secrete anything anymore. There's nothing that can make it secrete. If you see her and give her to do, sorry, it's going to be flat. Whichever. If the brain is damaged, there's no interaction. The variability is usually going to be flat.
One would, like, the process of damage.
Yeah.
Then you have high baseline and normal variability.
And you have high baseline and normal variability. Yeah. So if you're squinting at variability, always get worried. If you have a high baseline, you may have a high baseline before decompensation.
So you just wait for cycle.
Try and stimulate this baby. And in general, you don't fall asleep if you're tachycardic. If there's adrenaline rushing through your system, you don't normally fall asleep. If you're falling asleep, that usually means you're blacking out rather than falling asleep. That's why you've gone flat. It's not because you're happily falling asleep, yeah, or you're very sick, as in chorioamnitis, and you're very sick. That's why you just please close off. Does that make sense? So that was the scary case. Yeah. So had a cesarean section. They knew that the baby had brain damage. It was brain damage. I think they put on support for 2 weeks, and then they withdrew care.
That is baby.
That is baby.
So if you didn't have the first bit of the ceiling, you have the last trace.
Okay.
It doesn't look. What's the number? 100. Yeah.
Does that look normal to you?
No, but it doesn't look as bad as
you know
the
that
initial.
abrasion we had. You know that abrasion we had 2 weeks ago, the 26 week.
Yeah.
Antenatal CTG for the baseline of 140. And she came, and initially it was 80, on the sun cave, but then by the time we got to the monitor, it was like 110. Which is not normal for a 26 week.
It's very low for 26 weeks.
Yeah,
Yeah, I agree
yeah.
with that.
And it just takes, for like 15 minutes, the light to the 110. I mean, the variability wasn't like that. That's variability, not that.
That's not variability.
There's nothing there,
Next
but
one,
if you look
next
at,
one.
if you didn't see
This
that
one
one,
doesn't look so bad.
and you look at just this one,
So you're happy with this variability?
You can't call it diffuse.
I wouldn't
It's
be
very
jumping
up
like
and
the
down.
first one.
It's very like straight line up and down.
And it was like this. It was like this, but it was
Okay.
110.
So when you're assessing variability, okay, let's go back to the definition of variability. Yeah. So variability is assessed over a period of 1 minute, and it's the width, the bandwidth of your variation. Come on, point in where you would call it normal variability.
Yeah.
Yeah.
For how long? 30 seconds.
30 seconds.
So you have 30 seconds of normal variability, and I'm gonna
But then,
Couple of minutes. On and off.
I mean, I'm
come
still.
and look at it. I'm happy to accept if you can see normal variability that's lasting. So you assess episodes of 10 minutes at a time, and you always assess variability over 1
So you
minute.
have to have 10 minutes of continuous variability.
You need to have 10 minutes of CTG before you say there's good. But you assess variability over. I would never say that this is normal. I've
It's not
seen
normal,
traces.
but you wouldn't react like
So
the
how
first one.
much,
Like
how,
the
how
one
much
that's
space do
flatline.
you need of good variability to say that it's okay? Because I would say that's okay.
Okay,
Where?
let's imagine though that it was 140.
Okay.
Yeah, not that one.
I would
I'll
still
have to
not.
give it more time.
I would still not be happy with that.
But you
just have to
wouldn't
wait.
react to say to have a section.
So
You watch
if
it.
I'm saying, so what's making me react here is not that it's 100. It's 100. What's making me react here is the okay. So the only thing I can't explain here is why is it 100. To be very, very honest, I can't explain why it's 100 here. Okay.
Didn't say the heart times though.
So the heart beats normally between 140 to 120. So this is what I'm expecting.
Yeah.
Okay. I don't understand why here it's 100.
It's just a steady decline, isn't it?
Why was the heart? Why was it pretty much flatlining on the previous CTG?
Yeah.
And now there
And
is
then
something.
here
So,
there is something.
Remember, the squigglies happen with if there is hypoxia already happening. So the heart can slow down. So the only explanation that I may have why this is 100 is that the oxygen levels coming are dropped. That this is the only thing it can maintain. But I can't swear on that. That's just me making stuff up as I look at traces. Okay. So squiggly can sometimes happen when the heart is facing hypoxia. Okay, because ischemia can directly slow down the heart. What are you looking for? Does that make sense?
Yeah.
Do you remember there was a case that we demonstrated the other day about the lady who came in with tachycardia, so based on 160 or 140, it was accelerations or decelerations, got taken off the trace because they kept on giving her fluids, and the fluids kept on bringing the heart rate down a bit.
Oh, I remember that case. Yeah,
Remember that case?
I remember, yeah.
And they took her off. Yes. Yeah. So when they let's look at that trace again.
No, sure, I don't mind. Honestly. What do you want to?
Where it's on?
Sorry, you would need time.
More space.
That was my smash food in there.
She's in Q&A.
Yeah, it's mucosa. It's like actually not. It's not disgusting.
We're being recorded.
I'm sorry.
So-
Costa provides delightful food and very, very.
So if you remember this, okay, so that was the trace before, and they could discontinue the IV fluids towards the end, and you can see the baseline literally jumped back up. Can you see that? That's you go. Yeah, the moment they stop the IV fluid, it just jumped back up. This stops at 3 o'clock in the morning, and then 6:20. Okay. Now with the contractions, the squiggly. The squiggly is because of the actual hypoxia. So less oxygen coming, the heart will slow down in itself.
So right back here, this almost looks like
And
cycling.
completely normal. Yes.
Nice. Do you know what I mean?
Okay. So how do you figure this one out? You stimulate the baby. If you try and stimulate the baby, it will either respond or nothing at all.
It's that up and down again. It's like this.
Yes,
rather
that's
than
what I'm.
like that.
This is not a parasympathetic sympathetic slowing and increasing. This is not sorting out the whole body to get it down. This is the heart doesn't get oxygen, it stops. Okay, some oxygen just passes by, it beats once and then stops, and then a bit more oxygen, it's back to where it's supposed to be, and then it stops again. That's why? Remember, what you're measuring here is a rate. The rate is calculated based upon the number per the distance between, yeah? And this is not beat to beat, this is not actually every single beat. This is over the last few seconds, what was the rate of the heart? So the machine counts, here's a heartbeat, that's 1. Okay, here's the next one, that's 100 milliseconds, or 500 milliseconds. That gives me a rate of 120. But it doesn't do that with every single beat. It does that with a few beats, takes the average between them. Okay? That's why when we say Dawes-Redman, when we talk about short-term variability, we say you cannot detect that with your eye because Dawes-Redman counts each and every beat and counts the distance between them and takes the average, rather than takes the average of, the average time of these beats is that.
So I
think you missed a lot of hypoxic babies. So that's why I always say that I love decelerations. I love seeing decelerations because they tell me lots and lots about the baby. It tells you a lot more than just, baby's moved, baby's had an acceleration, which might even turn out to be a quick compression that looks like an acceleration. Yeah? But that is the classical picture of a brain injury or a brain damaged baby. Be sure to pick it. Okay? We always love babies responding in one way or another. The baby that comes in with these massive whatevers, yes, we need to deliver this baby fast, but this baby is not going to get into trouble because it's easy to pick up the panicking baby. But this baby is really tricky, and it can take hours before you get diagnosed, and then you're in trouble. Yeah.
It's delivered within 2 hours, but we've got like wide.
So how long will you wait to watch whether this trace will cycle? How long will you wait? 90 minutes?
Definitely not. Definitely not. Okay. Did you see how long she took before they moved her to labor ward? How long did they take? Not even 30 minutes. That's where they stopped it. That's where they make a decision. They're here moving to labor ward. This is 10:20. 22 minutes and she's on labor ward. She diagnosed it in triage. Okay? I wouldn't wait for 90 minutes on that. Never.
No, not this way.
And on that one, okay, not the same patient.
This one now. This one is.
That's why you know your physiologist. So if you're.
This one is a pencil line. Like a pencil line.
But that is the beginning of the trace.
Oh.
Okay? If you're starting the baby.
If you're starting with this bit of the trace.
If you're starting with this bit of the trace, are you happy with that?
I would take care of.
I would stimulate it. So the problem when you're starting here, you have no idea how long this has been going on for. That's when stimulation is crucial. Okay. I need to get a response from that. Yeah. Most of the babies do.
But if she's not in labor,
What if she's not in labor?
So you can still push the head. you can still poke the head, and you can use the scanner. The scanner creates noise around the baby, so acoustic stimulation. That
Oh, you
works.
look at it with the opposite.
Yeah.
Yeah.
Keep it next to its ear for a while, and it will wake up. It will. It does.
Oh, it's a therapeutic effect of the opposite.
It's not therapeutic. It's diagnostic still.
It's a diagnostic test.
The idea
We're
is,
still having this
don't
look at
just
the
wait
baby.
on that.
Yeah.
Do not just wait on that. If you stimulate the baby and the baby does not respond and the virility is still maintained reduced, the chance of it being hypoxic is more than 38%.
38%.
Yeah.
If
More
it
cancel,
doesn't,
it's not hypoxic.
if it doesn't respond with
If
stimulation,
it doesn't respond with stimulation with persistent reduced virility like that, 38%, more than 38% is hypoxic. Right?
So you're saying 60% harm.
True. If you want to wait and check those 60%. Okay. And remember, those are the times from pattern recognition. This is not the time from actual physiology. So you know the traces that you're looking for now. Yeah?
so if it doesn't have accelerations and it continues like this, then it doesn't.
If it doesn't have accelerations or decelerations, I would always deliver. I would not wait to find out whether this is a baby that's been asleep completely. That's why you're calling a friend.
What if it makes
So again, my advice to call a friend is actually to the seniors.
Yeah.
So you as a junior, you're always going to call your consultant. The reality is, if they have a discrepancy, it's their responsibility now. The fact that you've asked for help, so when you become a consultant, and okay, I'm not entirely sure what to do about this, that's when you ask for help.
Yeah.
Okay? If you've asked for help, the fact that you've asked for help means that you are A, not certain, B, you've already done a big part of this. You are saying, I don't know. Saying, I don't know is forgivable. While assuming that you know or insisting that you know, and then ending up with a problem, that is non-forgivable. That is negligence. Does that make sense?
Mm-hmm.
Because I can never swear or can never sit down here and say that we've figured it all out. Now we know exactly what to do in every situation. Absolutely not. But it's important to make sure that you know when to ask for help. That is very important. Yeah? Any other questions?